cardiometabolic comorbidities in psoriasis, and until now, we've done a lot in the molecular correlation with cardiovascular disease and psoriasis, doing a lot of research. But when you go to dermatologists, they always say around the world, okay, but I don't have time. I don't have time for this. This is too complicated. This is not for me. So then you say, when you advance in the field, okay, we need to move. We need to move to implementation, to do more practical things. So that's why we want to go to the practice and to change. If we really want to change the life of our patients and not only improve our CV, we need to make more public health and more prevention activities, and very, very practical. And I'm very happy today because I at the beginning of my career, I was introduced to IPC via Dr. Alan Mentor, one of the founder of IPC. And I'm very grateful to him, not only because of his help in my career, but also for the creation of this visionary organization, the IPC, who is helping and really promoting people around the world to improve the care of psoriasis. I still remember asking Dr. Puig to write letter of recommendation for me to go there, so thank you. And also the Spanish group of psoriasis at the beginning of my career also had a tremendous impact. So seeing both together for me is fantastic, and so congratulations, Dr. Carrascosa and Dr. de la Cueva, for this genius idea. And let's go to work. I always begin with this slide, and this is from Dr. Gelfand at 2009, mortality in patients with psoriasis. So we have been doing really well in improving the skin of our patients, but there are still many things we can do. 3 important messages in this slide. First, this is mortality. Blue line is psoriasis, and you can see that this line, the blue line, is shifted right. So they have an increased risk in mortality. Second important point, as you can see, most of this mortality is due to cardiovascular disease. And third point, look at the age of 40. Those lines are separated. There is an increase in mortality at the age of 40. So this is moving what we are doing in our research and what we want to do now. There are even new studies really suggesting that the skin disease severity really matters, and with every increase in 1 point of the PASI, or even 1 year increase in the duration of the disease, there is an incremental 5.8% and 4.6% increase in cardiovascular disease. So disease duration and disease severity matters. And this is related to many other things. So it's not only, the patient is not only a plaque in the skin or a plaque in the heart. This is unfortunately more complicated. And we began to talk about the metabolic syndrome. Then we moved to the cardiometabolic syndrome, and we now prefer to talk about immune metabolic diseases. Immune metabolic diseases. And this is something evolutionary, where some hormones can act as cytokines, and also some cytokines may act as hormones. So how can we explain this? Okay, we explain this in this study that we published in the Journal of Investigative Dermatology, where we found how patients with psoriasis, when compared to the general population, they tend to accumulate more fat in the liver, more inflammation in the liver, and that inflammation was related with cardiovascular disease and high-risk coronary plaques. So for your clinical practice, when you have a patient with psoriasis and you see in the report non-alcoholic fatty liver disease, don't worry only about the liver problems, but you need to be worried most about cardiovascular disease, and sometimes you need to use a statin there. Also now, new evidence is suggesting, we tend to think that psoriasis is promoting cardiovascular disease, right? Well, new evidence is suggesting that even cardiovascular disease could promote psoriasis, so even more complicated. And maybe this is the reason why we sometimes don't do this in our clinical practice. It seems to be like it's not clear, everything. Okay, Álvaro, but you said that you are going to be practical and you are talking about theory. What can I do in my clinical practice? Okay, sometimes you are a motivated dermatologist and you study a lot and you go to cardiology guidelines, you do the cardiovascular risk scores, the Framingham risk score, and you are motivated in your clinic, you sit there with your patient, you do that, and you say, okay, you are a low-risk patient. You can go and be free of cardiovascular disease. So in those patients with low cardiovascular risk, we did imaging in the coronaries. And what we observed is that those patients with low risk, based on the risk score, they actually have high coronary risk. So they were not useful. So maybe you are losing your time if you do this. So what can we do instead of this? To answer this, we built here in Madrid a cohort study. So we follow patients, and I remember a conversation with Mark Legwell, and he told me, Álvaro, you need to follow those patients. Don't do transversal studies, cross-sectional studies. You need to follow patients. See, like the cardiologist, see in years and years. So that's what we are doing here. We do a baseline cardiovascular phenotyping, imaging, and molecular phenotyping, and we follow patients. And we are learning a lot, and I want to share with you what we are learning from there. So you remember epidemiological studies suggesting that these patients have cardiovascular disease early in their lives, and then in my clinic, I see these patients for research, not for clinical practice, but when we do the studies in the coronaries, sometimes we do this on Thursdays. On Friday, I receive a call from the cardiologist, and when I see the call, I say, this is bad news, okay, and this happens a lot. And she called me, Álvaro, what age is this patient? I said, 48-year-old, no cardiovascular risk factor. Okay, look at his coronaries, 90-something% in every coronary and without any cardiovascular risk factor. So we call the cardiologist in our hospital and they go to a stent. And this happens a lot again. So we want to prevent this in our patients, and that's why we are here. We do imaging. I'm not going to stop here because we want simple things. We are now bringing evidence into, for example, going outside. You know why Einstein is there? Because if you want to look to find different results, you need to look different things. We have been looking for IL-17, IL-23 a lot, and then we do a discovery without any bias study in cardiovascular disease, and we found that the complement system in psoriasis is key there. So maybe cardiovascular disease is different, and we found this interesting not only for biomarkers, but also for new therapeutic target in psoriasis. But we want to be practical. So I will stop here. This is from our collaboration with Dr. Nihal Mehta. ApoA. This is simple because in most of your hospitals, you should have this. We have that in our clinic. And this is interesting because we follow this patient over time. We followed this patient for 4 years. And you know what? If you do this, for example, every time you order a blood test for your patient for your biologics, we could observe, I must say that ApoA is good for you, so it's protective. Look at there, for every 10 unit decrease of ApoA, it was associated with a 16% increase in high-risk coronary plaques. So now you know, if you follow your patient and you send a 10 unit decrease, you know that actually your patient is, the coronary of your patient is worsening. So this is practical, right? And we can do this tomorrow. I'm not going to get into these details, but just to let you know that there are new indexes like this triglyceride glucose index is simple and has also been related with cardiovascular disease in psoriasis. I want to stop here. This is about to be published now from our group. This is monocyte HDL index. This was presented last year in the GPS. And again, I want to present because it's simple for daily clinical practice. And it's a combination of what? Immune metabolic disease. Immune monocyte, metabolic HDL. And it's simple. You have already in your patient. You can calculate. If it's higher than 24, your patient have an increased risk, 60% increased risk of severe coronary disease. So simple, and you can do that. So this is the question of Dr. Mehta this year. How much more evidence do we need before becoming proactive here? And this can be very simple with the 3 Bs, just 3 Bs. Blood pressure, BMI, and blood work to do these simple biomarkers, okay? So sometimes we say, okay, but that's the role of the GP, the general practitioner. I don't have time for that. And we think that they are doing that. So we wanted to know, and we did this survey with the Spanish group of psoriasis, also with the Rheumatology Society, and we asked GPs, we asked rheumatologists, and we asked dermatologists from Spain, who is doing what? Are you actually measuring cardiovascular risk in your patients? And you know what? 70% of general practitioners, they didn't consider psoriasis as a risk factor. So we are doing a lot of symposium, a lot of work among dermatologists, and maybe we need to move and we need to change the way we work, or at least we need to know this to implement new activities. But hopefully you can see there, and we are very happy that a lot of dermatologists, they want to learn how to begin an statin. So this is positive. And sometimes people say, Álvaro, you are overdoing this about the statin in psoriasis. It's just another thing. Psoriasis don't need more attention. And look at this paper. This is a recent paper among people with type 2 diabetes. They look for the use of statins, and look at there at the bottom is psoriasis. And psoriasis in this group of people was a risk factor for a reduced likelihood of the use of a statin. So having psoriasis is a risk factor for not using a statin. So, and this is new, this is recent among many people. So more reasons to use a statin in psoriasis. So what can we do? Again, a statin, this is what is the hot topic now. So as we want to do things that can be done in many different countries, we want to implement this, and not just like I'm a motivated dermatologist and I do that in my clinical practice. And with the help of Dr. Puig coordinating this study from the European Academy of Dermatology, we did a consensus document with the only aim to make it simple for dermatologists. We wanted to make it simple. So this is simple guidelines that you can go through. I will only say here the current level of LDL for your patients should be 100 milligram per deciliter. And some people tell me, you are crazy. No, and the answer will come at the end of this presentation. You will, in the future, we will have 70 for sure. So we need to take this into our minds. If you don't want to begin a statin, that's okay. We can refer, but at least we are looking the blood test of our patient on a daily basis. So we can just see that and refer to a specialist or just begin the statin. Also, another things, unmet need in psoriasis, this residual inflammatory risk. You know, cardiologists, they are very worried about having a CRP above 2. CRP above 2 has a strong relationship with cardiovascular mortality. We in psoriasis don't measure much CRP, but we have done a preliminary studies which are going to be published very soon. Among patients under biologics, we measure CRP in 3 different cohorts, the Spanish cohort, United States, and Karolinska Institute. There is a 40% of patients who still have CRP elevated. So the message here is that sometimes we treat our patient, we think that it's done because the skin is completely clear, but we still have some task to do here. And maybe we need to do other different things rather than biologics. And that's why we began this clinical trial trying to evaluate the impact of the Mediterranean diet together with treatment for psoriasis, trying to reduce these cardiometabolic risk factors. If you want a picture for the slide, this is the algorithm that I love the most, because you can see that the levels, they are updated, LDL of 100, including BMI, which is so important. BMI as a criteria for starting statins, also smoking and family history of cardiovascular disease. Sometimes we say, we don't have any genetic test for cardiovascular disease in psoriasis. Every of my patients, I always ask in my clinic, family history of cardiovascular disease. That is a genetic test you have just with a single question, and it's very useful. Most of the time you ask this, he will smoke, he will have like hypercholesterolemia and many reasons for beginning a statin. The last question is, if I treat my patient with psoriasis, do I just by treating psoriasis improve cardiovascular disease? This is a very difficult question. I don't have time today. Observational data say yes. Clinical trials, you can see there with data meta-analysis and published in the investigative, say it's a question we don't know now. What do I say to my patient? I always say that the current psoriasis therapy offers the promise of decreasing the risk of cardiovascular disease, so you need to treat your psoriasis. This will be presented tomorrow here. This was presented as a late breaking in the AAD. These are mortality multimarkers. This is not cardiovascular disease, mortality. Mortality includes also liver mortality, which in psoriasis is increased. These are biomarkers. Tomorrow we will present here how they predict mortality in psoriasis with very interesting results and a longer extension of this. Here, to make the long story short, just to mention that adalimumab shows improvement, secukinumab showed neutral effect, and phototherapy also neutral effect with improvement in ApoA with phototherapy. So really interesting. What is the future? For the end of my presentation, where are we going? And we love this paper for the New England Journal of Medicine. They included HIV patients with low cardiovascular risk. They did a 5-year study, statins versus placebo, because it wasn't indicated. They needed to stop the trial because cardiovascular disease was reduced in the intervention arm. This is what, for example, Dr. Gelfand is planning, what we are planning, including a study like the cardiologist, thousands of people with psoriasis randomized with low risk, and whether statins not only reduce mortality but also reduce the psoriatic arthritis, or this is what we need in psoriasis, and this is what we need to plan. And I told you that about the 100 milligram per deciliter LDL, that it was not crazy, right? So when we asked Dr. Valentin Fuster, he will begin this study in 2 months. General population, people from 20 to 40 years old. People from 20 to 40 years old in the general population, he's going to randomize them to have an LDL below 70 from 20 to 40 years old. Because the idea now is we have early intervention in psoriasis, they have early intervention in cardiovascular disease. They think, and they have a lot of evidence supporting that beginning statins over 40 years old is too late, that you cannot reduce atherosclerosis properly, that treating adult people and over 40 is too late. They are not going to use statins here. They are going to use a PCSK9 inhibitor, twice injection a year. It can have effect in psoriasis as well, and this is also what we are thinking about doing. So for me, the conclusion is, if in the general population they are doing this is what are we doing in psoriasis, right? We should be doing this even earlier, and we need to do the trial. We cannot just begin to do it. So the future is here, and we hope we can do a study together. This is the summary. We need to do this in our daily clinical practice. If you want to do this simple, just the 3 Bs with simple biomarkers. Remember, sometimes what's happening in the skin is not what's happening in the inside, residual inflammation. We need to educate our patients, and this lifestyle modification, which are important, and we need to incorporate in our daily clinical practice. Thank you so much.